Good
Sir,
evening.
good evening, sir. Good evening. How are you, sir?
Good evening.
Your presentation, the revised one which you have said, you added a lot of things and made it very interesting.
Yeah, I have actually I have revised again.
Okay.
So I have not been able to send that.
Acha.
Yeah. You want me to send that now? But it's okay, no problems.
Acha. But you are going to present that one, na, which you are now prepared.
Yes.
I don't think there will be any issues.
Some slides are added, that's all.
Yeah, fine, fine. Sir. But a lot of hard work, I think, I have seen. Because I saw some of the Sun Pharma slides, but many are new, which you have added.
It was a lot of places I have added things, actually.
Right. Very nice. Sir, the invitations have gone to your people.
Yeah, I have sent, yeah.
Sujit sir, you got the CV of sir?
Yeah, I'm sending you.
Yeah, please. You're sending me a WhatsApp?
Yes. It is a handwritten one, so I'm just sending you that.
Yeah, please.
Dr. Komal, Dinesh sir, Dr. Komal, our medical advisor.
Okay.
Hi, sir. Hi,
yeah.
Good evening, sir.
Yeah.
Thank you for accepting the invitation and as a speaker. So initially, I will introduce you, sir, and then hand over the session to you.
Okay. You are Dr. Komal.
Dr. Abbas, sir. My name is Komal. Komal Abbas.
Komal Abbas. Okay.
So
I was saying Dr. Abbas, so that's why I said.
right, sir. Yeah.
So initially, I'll be speaking on the hemorrhoids, and then you'll be speaking on aldosterone, right?
I will take 3 to 4 minutes.
Okay.
Only unique features about aldosterone I will highlight.
Right.
And then, sir, we'll go ahead for question and answer.
Yeah. Because I was worried, I was combining, so I said then whether I have to skip all those things of micronized purified.
Yeah. MPFF, right? MPFF I will cover most of the part. And you can highlight in your presentation.
I have already highlighted some things.
Yes.
Yeah, no problem. Perfectly fine.
Sir has highlighted it very well, sir. In fact, jo balance rahega, that you can, cover.
Yeah. We will avoid the repetition. Sure.
Yes.
From 1000 to 500 milligram. So doses I have changed. All those things which I did finish afterwards. So.
Okay. डॉक्टर अब्बास मैंने आपको भेज दिया है, चेक कीजिए.
I have forwarded you the latest version also. Just see if you want.
I'll see.
Received, sir, received. I'll just forward it to the technical team.
Yeah. we have on the AC, so whether it is disturbing the voice, noise.
We can now hear you properly, sir.
There is no problem, no?
Yes, yes, no issue.
Okay. Sound like a supplement.
Dinesh, I'm facing few internet issues. That's why I have logged in from a cell phone.
Okay, ma'am. No problem, ma'am.
Well, we are connected, so we can take care. Tell me what to do.
Yeah, the flow of the event is decided in such a way that Dr. Komal will open the session. He will formally introduce Dr. Hegde, and then we will continue the session with Dr. Dinesh only. And the moment session is over, Dr. Komal will take few slides on aldosterone and then question answer. And thank you note would be given by Sujit sir.
Okay, I think exactly the way we discussed that day, right?
Yes, right. So, Dinesh, if we are fine, it's 5 o'clock. Please go ahead so that Dr. Komal can initiate the session.
Okay.
Yeah.
Should we wait for 5 minutes right now? Because I was just checking the audience. It's around 20 people are there right now. Should
The
we start or should we wait?
number will go up, Sudhirji, by 5. People tend to log in at 5 and then it will increase. I mean, your choice. I leave it to you.
Another like 2-3 minutes we'll wait.
Yeah, your call, Sujit. So we'll wait if you wish.
I think we should start.
Yes, I think that's
We
right.
should go live now. Yeah. Dinesh, can you take us live now?
Pardon?
Yes, sir. We are live now.
Okay.
Komal, all yours.
Thank you. Good evening, everyone. I am Dr. Abbas from medical team of Sun Pharma. It gives me great pleasure to extend to you all a very warm welcome on the behalf of Sun Pharma for today's aldosterone conclave webinar on hemorrhoids. At Sun Pharma, we believe in connecting eminent faculties from around the world for exchanging their skills and experiences with each other, which in turn benefits the patient care. Today's webinar is one of the such events. With this idea, I take this opportunity to welcome today's speaker, Dr. Dinesh Hegde. Sir is Consultant General Surgeon at, and he is an honorary surgeon at Rajawadi Municipal Hospital. He is also Associate Professor at D.Y. Patil Medical College, and he is also having his own setup with the name of Hegde Hospital and Surgical Nursing Home in Chembur. Sir has done his graduation in medicine from Mumbai in 1981 and post-graduation in surgery in 1985. He is a rank holder in surgery examination from University of Mumbai. Sir has also done fellowship of All India Medical Society. He has done DOH from Dubai and postgraduate diploma in medical legal systems from our country. Sir has 35 years of a huge experience in surgery. He is head of the Department of Surgery, Rajawadi Municipal Hospital. As I told you, also Associate Professor at D.Y. Patil Medical College. He is also examiner for MBBS exams in Mumbai University. He is the ex-president of Surgical Society of Chembur. He is a professor, American University of Seychelles for postgraduate studies. And he, as I told you, he owned a 25-bedded hospital in Chembur and is a director in the same. In addition, he has also qualified laparoscopic surgeon and he has a qualification in laser surgery also. With this short introduction, now I request doctor to take the session ahead. Over to you, sir. Dr. Dinesh, over to you.
Yeah. Good evening. You are able to hear me? I am audible?
Sir, yes, you are audible and visible also. Yes, sir. And slides are nicely visible, sir. Yes, please go ahead, sir.
Good evening, friends and colleagues. I thank Sun Pharma for inviting me for this webinar. And I thank all the people who are watching, because on a Sunday evening to watch this webinar in this COVID pandemic, I thank them. Hemorrhoids is a very common topic. And in our country, many of them are suffering from this. But what happens is, because of social stigma, they suffer for quite some time and take treatment from different quacks and then come to the surgeon. 90% of the patients don't come, only 10% of the patients come, and many of them come after having a lot of complications. Lowe and Bailey said, hemorrhoids is the penalty man pays for his erect posture. One minute. Just little, I'm having some problem. Definition of hemorrhoids. Hemorrhoids are defined as the symptomatic enlargement and distal displacement of the anal cushions. There is abnormal dilatation and distortion of the vessels with destructive changes in the supporting connective tissue of anal cushions. There is dysregulation of the vascular tone or vascular hyperplasia. All these are important because each and every part has to be tackled while giving treatment. Classification of hemorrhoids: prolapsing internal hemorrhoids and external hemorrhoids, and mixed internal and external hemorrhoids. Classification of hemorrhoids based on their anatomic origin within the anal canal and by their position relative to the dentate line. Internal hemorrhoids, no innervations, so not painful. 3 o'clock, 7 o'clock and 11 o'clock positions are the common sites of internal hemorrhoids. External hemorrhoids can be present anywhere. And external hemorrhoids are painful. Gallagher's classification of internal hemorrhoids: grade 1, protrudes into the anal canal but does not prolapse. Grade 2, prolapses but reduces spontaneously. Grade 3, prolapses and requires manual reduction. Grade 4, irreducible prolapse. The Association of Colon and Rectal Surgeons of India have further classified it into A, single pile mass, B, 2 piles but less than 50% circumference, C, circumferential piles occupying more than half circumference of the anal canal, D is thrombosed or gangrenous piles or complicated piles. Risk factors for hemorrhoids: strong risk factors more than 2 is constipation and diarrhea. Moderate risk factors are low fiber intake, a history of childbirth, obesity, pregnancy, non-sedentary behavior, depression. In this pandemic, lot of youngsters are coming to me for treatment for piles, because one is the food habits among youngsters, which is more oily and fatty, and second is prolonged sitting, because they are doing job from house in front of the computer, sitting for a very long time, and that is why a lot of youngsters are coming with these hemorrhoids problems. Pathogenesis of hemorrhoids is dilatation of the vessels of hemorrhoidal cushion. It is caused by inflammation and fragility, increased tone of the internal anal sphincter, and deterioration of the connective tissue. All three causes this. Coming to the symptoms, bleeding is the most common symptom. Bright red blood due to direct arteriovenous communication to the anal cushion. Blood seen on the surface of the stools or dripping in the bowl or on the tissue paper during anal cleansing. Most of the times, history will only tell you whether patient is suffering from hemorrhoids, fissure, or bleeding is from higher up. If the patient says that the bleeding is like a fountain, that most of the time indicates that it is from the fissure. If the patient says, as I told you, that blood seen on the surface of the stools or dripping in the bowl, then it is because of hemorrhoids. If blood is mixed with stools, it suggests bleeding from elsewhere in the GI tract. Prolapse depending on the grades of hemorrhoids. Pain if thrombosed or strangulated hemorrhoids or associated with other painful anorectal conditions, or infection in a thrombosed pile. Clinical features, it has been found in a study of 40 patients in 1 year that 85% of the patients had bleeding and mass per rectum. 77.5% of the patients had pain during defecation. 22.5% of the patients had soiling of clothes, and 12.5% of the patients had pruritus. Diagnosis of hemorrhoids, as I told you, that history itself will tell you the diagnosis. The statement of Bailey-Love, I remember, is if you don't put your finger in, then you'll put your foot in. That means per rectal examination is a must. So most of the times, if the patient has got fissure or external hemorrhoids, he will have a lot of pain and he may be hesitant for per rectal examination. So what actually should be done is lot of xylocaine jelly can be applied and you wait for some time and then do a per rectal examination. If most of the times the blood which is there is on the side of the finger, if you find sometimes blood on the tip of the finger, then you should suspect bleeding from higher up. If you suspect bleeding from higher up and there is no active bleeding from lower down, then it is better to do, first is proctoscopy, which should be done in hemorrhoids to see the grade of hemorrhoids, as proctoscopic grades of hemorrhoidal diseases are seen here. Sigmoidoscopy nowadays, at least in urban places, nobody does it. Basically, they directly go for colonoscopy if it is suspected. Otherwise, sigmoidoscopy is still being done in rural places. Management of hemorrhoids. Objectives of management of hemorrhoids are, as I told you before in the definition itself, to eliminate mechanical and local triggering factors, to reduce the inflammation always present in acute manifestations, to re-establish optimal hemodynamic and microcirculatory conditions. Treatment of hemorrhoids consists of conservative and definitive. Conservative management involves dietary and lifestyle modification, medications for symptomatic relief, sitz bath. Definitive treatment involves office procedures like rubber band ligation, sclerotherapy, infrared coagulation, surgery, which is all types of surgery, which I will discuss afterwards. Dietary and lifestyle modification. Most of the patients who come to your clinic would always say, please give medicines first and let us see if medicines control the piles. And then once the medicines do not control their symptoms or problems, then they are willing for surgery. Nobody is willing initially when they come first to you for surgery. So better to give the medical line of treatment to the patients, and for grade 1 and grade 2 especially. Dietary and lifestyle modification involves fiber supplement, and it has been found that in 50% of the patients, fiber supplement helps in minimizing the risk of bleeding and the problems. The advice usually includes increasing the intake of dietary fiber to 20 to 30 grams per day and fluids to 1.5 to 2 liters per day. Having regular exercises, refraining from straining, and reading on the toilet. And nowadays, people take their mobile phones and watch WhatsApp and other things on the mobile, and that is also a cause for getting hemorrhoid. Avoiding drug-causing constipation or diarrhea, analgesics, anticholinergics, opioids, iron supplementations, etc. To limit intake of fatty food and alcohol, because it exacerbates constipation. As I already told you, the youngsters are more involved into the fast food and alcohol, and that is why the problem is more happening in the youngsters. Laxatives can be given, propylene glycol, lactulose, bulking agents to help in constipation. Medical management is appropriate for grade 1 and 2 hemorrhoids. All patients with hemorrhoids should maintain soft, bulky stools that can be passed without straining. This is also important after surgery because straining and passage of hard stools increase pain and bleeding and delay healing. Adequate intake of food and fiber helps soften the stools. Medical management involves non-prescription topical preparations containing steroids, anesthetics, astringents, or antiseptics, which are often recommended for all grades of hemorrhoidal diseases. However, no randomized studies support their use. Steroid-containing creams should not be used for prolonged periods because of their atrophic effects on the skin. Sitz bath commonly recommended, but a review of studies found no benefit for various anorectal disorders, including hemorrhoids, but it gives a psychological relief to the patient. And usually sometimes we tell them to put in betadine into the sitz bath warm water and sit in it, which helps in antiseptic way. Flavonoids, most common phlebotonic agents used for treating hemorrhoids. Oral medications for management of hemorrhoids. Drugs are either used as a defensive treatment for early grades where prolapse is not significant, or as a primary control of the acute bleeding. Till definitive office procedures or surgery can be done. Drugs for medical treatment of hemorrhoids. Venoactive drugs include flavonoids, MPFF, diospin, oxyrutin, euphorbia prostata, Incrago, heparin sulfate, calcium dobicerate. Basically, it improves the venous tone, microvascular permeability, activity, circulatory flow, and may reduce bleeding associated with hemorrhoids. MPFF has high level of evidence and strong recommendation, but others have not been proved beyond doubt.
Excuse me, sir. Nishant, please put off your mic. Nishant, please put your mic on mute. Nishant, please put your mic on mute. Nishant, please put your mic on mute. Sir, please unmute yourself. Sir, please unmute yourself. Go ahead, sir.
Shall I continue?
Yeah, please, sir. Go ahead.
Okay. MPFF, what is it? It's a unique combination of flavonoids. It is micronized purified flavonoid fraction. Is a unique combination containing flavonoids, diosmin, hesperidine, linarin, isorhoephyllin, and diastepatin. Micronized flavonoids means particle size is less than 2 microns, improves extent of absorption of MPFF and its metabolites. Has better clinical efficacy. MPFF breaks the vicious cycle of chronic inflammation and protects the hemorrhoidal plexus. It inhibits expression of adhesion molecules on leukocytes and endothelium, limiting leukocyte infiltration and migration. Mechanical, it increases the venous tone and potentiate the contractile response of noradrenaline. Medications aimed at treating underlying causes offers better chances of preventing progression towards severe prolapse and thrombosis. A cycle of inflammation and prolapse ensues. So that is prevented by this MPFF. MPFF in acute hemorrhoids, recommendations grade A level 1, grade 1 hemorrhoidal disease, first line treatment is MPFF 500 milligram into 2. Grade 2 hemorrhoidal disease, first line treatment is MPFF 500 milligram into 2. This is the recommendation actually. Acute hemorrhoids, 6 tablets, that is 3 tablets twice a day for 4 days, or 2 tablets 3 times 4 days, and then 2 tablets twice a day for 3 days. And to prevent relapses, 2 tablets daily can be given up to 2 months. Use of MPFF in grade 3, grade 4 hemorrhoids with procedures is 6 tablets for 4 days, and then 4 tablets totally for the first week, then 2 tablets daily for 2 weeks after hemorrhoidectomy or previously. It has got proven efficacy in reducing post-operative symptoms. MPFF was effective in alleviating symptoms after hemorrhoidal surgery and improved the proctoscopic appearance. Therefore, it should be considered initially for patients presenting with hemorrhoidal symptoms and then afterwards surgery. Pain post-operatively also reduced when MPFF was used. As you see in placebo, the pain was more, and in MPFF, the pain was less. Use of MPFF, the pain was less. MPFF guideline recommendations of different journals is American Gastroenterological Association. MPFF was recognized as the pharmacological treatment of reference with outstanding efficacy in hemorrhoidal disease. French Society of Coloproctology, MPFF was awarded the highest grade of recommendation among oral treatments. In evidence-based gastroenterology, MPFF is considered as the reference venoactive drug in the treatment of hemorrhoidal disease. Drugs and drug treatment of hemorrhoids, MPFF is now recognized as the reference pharmacological treatment for the medical management of hemorrhoids, whatever the stage of the disease. Consensus group recommendation, management of hemorrhoidal disease with MPFF is grade 1, diet and lifestyle modification plus MPFF therapy. Grade 2 is diet and lifestyle modification plus MPFF therapy. If insufficient, then non-surgical outpatient procedures plus MPFF adjunct therapy. Grade 3, physician assessment, non-surgical outpatient procedures plus MPFF adjunct therapy, surgical procedures plus MPFF adjuvant therapy. Grade 4, surgical procedures plus MPFF adjuvant therapy. Indications of surgical procedures: external hemorrhoids as they are painful, large or irreducible prolapse, strangulated hemorrhoids, long-standing symptoms with failure of medical treatment, recurrent or persistent bleeding from hemorrhoids requiring blood transfusion, and grade 3 and grade 4 hemorrhoids. Surgical treatment has undergone a change over a period of last 30 years. Previously, we used to do open hemorrhoidectomy, which I used to regularly do it, and then came into closed hemorrhoidectomy, but the patient suffering was quite a lot. Post-operatively, 6 to 7 days, 3 days, patients used to be hospitalized, patient had pain, patients continued to have pain till all the wound healing was done, and the treatment used to continue for months together. Stricture formation was very high. Then came in minimally invasive stapled hemorrhoidectomy. Stapled hemorrhoidectomy was quite done by a lot of surgeons, and then lot of complications like stricture also happened. But still stapled hemorrhoidectomy is done by a lot of surgeons all over India. I have been doing now laser hemorrhoidopexy. It is called as hemorrhoidopexy because nothing is removed. The hemorrhoid is burnt and coagulated and fibrosed. So I will talk on laser hemorrhoidopexy. There was Doppler guided hemorrhoidal artery ligation also. I really do not know how many people are doing this. Infrared coagulation, I was in Dubai for some years practicing there in between, and there lot of patients used to come for office procedures. They did not want to get admitted, and infrared coagulation was a very good procedure as it can be done under local anesthesia and the patient can immediately walk from your operation theatre. But the recurrence rate is very high, more than 25 to 30% recurrence rate is there. Stapler hemorrhoidectomy, wherein the stapler is used, it is supplied by the Ethicon and other companies. Laser hemorrhoidectomy. Laser, what is it? It is a light amplification by stimulated emission of radiation. Light of the laser is transformed into heat for soft tissue cutting, ablation, vaporization, hemostasis, and coagulation. Ablation means removal, especially by cutting with a laser or electrocautery. Vaporization is to turn or cause something to turn from a solid to liquid state into gas. Coagulation is the process by which blood changes into a solid state to form a solid seal. Laser hemorrhoidoplasty, first described in 2009, technically simple, minimally invasive, safe and effective procedure for symptomatic hemorrhoids. LHP is done using diodo laser. I have a laser machine from Lasertronics, 1470 nanometer wavelength with sharp tip laser fiber. Laser fiber is introduced until the level of hemorrhoidal pedicle and coagulation is activated. I introduce the laser fiber external to the external sphincter and then go in. But under the lot of people also introduce the laser under the mucosa and go up to the top. A total of 250 joules is upper limit of energy delivered per hemorrhoidal quadrant. Smaller hemorrhoids are treated with less energy. The procedure is repeated in other quadrants, thus treating all anal circumference. Advantages: no significant intraoperative complications. Post-op pain is low. No post-op spontaneous bleeding. Daily activity in 2 days. Recurrence is less. No special anal hygiene and low surgical time. The procedure of laser hemorrhoidopexy, 8 watt energy is used, which is used in a continuous mode. Fiber type is a bare fiber, 600 microns. Dosage is 150 to 350 joule per segment, depending on the size of the hemorrhoids. Has to be delivered at the apex of the hemorrhoidal mass in the submucosal plane. Energy has to be delivered inside the venous plexus. Effects are absorption of the energy by the tissues and destruction of the hemorrhoidal vessels, followed by fibrotic shrinking and reduction of the hemorrhoid tissue. I will show you this video, how it is done.
So his main complaint is that bleeding
Here at the pedicle, on the mucosa, we burn a little bit so that the mucosa fibrosis occurs at the pedicle, but it should be very, very less. Then we go external to the external sphincter, palpate and go external, and then go up to the base of the hemorrhoid, and the burning is done. Up to about 350 joules of energy can be delivered, but you have to make the movements like an arc, not keeping the laser more than 2 seconds at a particular point. And you should be careful that we put our finger in to see that we don't penetrate the mucosa. Because if you penetrate the mucosa, then profuse bleeding can occur, and secondly, fistula can happen. So you have to take utmost care not to penetrate the mucosa or burn the mucosa from inside. The pile's mass shrinks in front of our eyes. Sometimes a big pile mass is there, more than 250 up to 450 we use, but we have to be very careful. And ice packs have to be put in immediately after using the laser, so that the laser energy does not spread all around the tissues and burn other tissues. When you introduce the laser, you will hear a crackling sound when the burning occurs. That is an indication that the pile mass is totally burned. And the whole pile mass, you will see afterwards that it shrinks in front of your eyes. Ice packs have to be put in, as I told you. It's a very, very simple procedure, and patients are happy because there is literally no pain afterwards. See, the whole pile mass has shrunk completely in front of your eyes. Complications of laser hemorrhoidopexy immediately is bleeding. As I told you, if the mucosa is penetrated, then bleeding can occur and burns. Delayed is bleeding, infection and abscesses. Infection and abscesses occur sometimes if the tip of the fiber is broken inside. So you have to be really careful when you are introducing the fiber with the cover, because the tip of the fiber is out of the cover. So never force it, slowly burn and go inside. Basic points to limit heat energy damage and necrosis. Bare fiber tip should never touch the mucosa while delivering the energy. Tip to remain in the submucosal plane. Tip of the laser fiber should not be at a single point for more than 2 seconds. Moving the tip sidewise is very important for even distribution of the laser energy in the tissue. For second degree hemorrhoids, 150 to 250 joule per segment is enough. For third degree hemorrhoids, 250 to 350 joule per segment is to be done. Machine setting is at 8 watts. Lasertronic machine has already got all these things preset in. Apply ice after delivering energy at each segment. The comparison of stapled versus laser hemorrhoid surgery. In stapled hemorrhoid surgery, tissue is removed. So chances of stricture are more. No tissue is removed in laser surgery. More pain, very little pain. Chances of stricture, no chance of stricture. Fourth degree can be done in stapled. Second and third degree is done in laser. But even I have done for fourth degree also, because it causes fibrosis and the whole pile mass shrinks in and it goes in. Rarely post-operative bleeding, no post-operative bleeding. Rarely incontinence, no incontinence. Requires hospital stay, daycare procedure. Thank you very much.
Thank you, sir, for a very informative and elaborative presentation, an excellent video, which was very educational one. Now I request you to stop sharing your slide so that I can share mine. Yeah, thank you very much, sir. Yes. Yeah. Dear viewers, I am very happy to introduce our brand of MPFF, that is Eldosmin. So we are introducing in acute hemorrhoids Eldosmin, which is a MPFF, which is a combination of diosmin and aspirin, as highlighted by sir. It has 90% of diosmin and 10% of aspirin. We have two formulations, 500 milligram as well as 1000 milligram. And this formulation is approved by DCGI. So you can very well prescribe. It's not an Ayurvedic or any other formulation. It is approved by DCGI as a drug, so you can very well use it. Now, what are the advantages in acute hemorrhoids? So during acute hemorrhoidal attack, patient may have various symptoms. So Eldosmin controls the bleeding. You can see in this graph, the bleeding is controlled in 44% of the patient by day 2 and 92% of the patient by day 4. So if you give it, you will find that within 4 days, the almost 92% of the patient will say that the bleeding has stopped from the hemorrhoids. It also reduces the relapse of bleeding. If you continue this medicine for 4 weeks of treatment, after acute treatment, it will reduce the relapse of bleeding in 18% of the more patient as compared to placebo. It also reduces the edema. So you will find that it significantly reduces edema and pain as compared to placebo if you use it in the patients of acute hemorrhoids. Now, it is also important during surgery, as sir was highlighting, that it can be used during the surgery. Now, pre-operatively, if you use it, what advantage it gives to the patient is, it controls the bleeding in 92% of the patient within 4 days. And it gives some time to patient to think about the surgery, to take a decision about the surgery. As sir was telling that no one will be ready to go ahead for the surgery on very first setting. He may need some time to decide on a surgery. So this Eldosmin will be very handy in controlling the bleeding when patient comes. Intraoperatively, as I told you, it reduces the edema. So the surgical field will be very clear, and very clear surgical field is important for successful surgical procedures. Post-operatively, it will reduces the risk of post-operative bleeding or bleeding after hemorrhoidectomy. So there will be no secondary bleeding, number one. As well as you will find that the post-operative recovery of the patient will be a quality one. So patient will have quality post-operative recovery when you continue to use Eldosmin in post-operative period. Thus, it acts as an adjunct to treatment in the surgery. So addition of MPFF to the local application of infraradiation or infrared procedures control bleeding in 15.2% of the more patients. So it will, along with surgery, it will help in controlling the symptoms. So it has a role pre-operatively also, intraoperatively also, and post-operatively also when you are using it in hemorrhoids. This also has Eldosmin or MPFF has been also studied in pregnancy, and it has been found that it is acceptable and found effective in treatment of hemorrhoids in pregnancy after in the 3rd trimester, I can say in more than 28 weeks of gestation. So you can very well use it in the pregnancy or during the pregnancy. Now, as highlighted by the sir, that the initial 4 days in acute hemorrhoidal attack, you have to use 3 grams per day, and then per day for 4 days. So there are 2 formulations which we have. One is we have we have 500 milligram. So you can use 6 tablets for 4 days, or some doctors use 1000 milligrams tablets. So they use 1000 milligram tablets 3 times a day. Or you can use 500 milligrams, 6 tablets, 3 tablets in the morning, 3 tablets in the evening. So sir was telling about 6666. So 4 times 6, and then you have to use 4 times 4, 4 times for 3 days, wherein you can give 2 grams per day. So you give either 1000 milligrams 2 tablet in a day, or you can give 500 milligrams 4 tablets in a day for next 3 days. Now after this, you can continue the treatment or a maintenance therapy for 2 months or more as recommended by ACRSI. Now this will help in preventing the recurrence or the reappearance of the bleeding in the patients of acute hemorrhoids. Now, how it really acts? Sir has very well highlighted in his presentation that it has anti-inflammatory property, because of which it prevents it take care of hemorrhoidal pathophysiology. Now, if you look at the left-hand side flow chart, because of the increase, because of the stasis of the blood in the hemorrhoidal stump, there is activation of the endothelial cells, which further to which WBCs adhere, and they get activated and they infiltrate the hemorrhoidal stump, and you will find that there is an inflammation in the hemorrhoidal stump. And because of this inflammation, you will find that there is increased capillary permeability, which increases the fragility of the hemorrhoidal stump, which leads to the necrosis of the vessel wall. And you will find that whenever there is a strong, whenever there is a hard stool which passes and which injures the stump, it leads to bleeding. So how MPFF is working? So it stops the activation of endothelial cells and leukocytes. So the inflammatory process, which is important one, is taken care by MPFF. Secondly, it improves the venous tone, improves the microcirculation, and again it controls the bleeding. So as told by the sir, if the medicine is controlling the pathophysiology of the disease, it will have the best effect in the patient. Now, aldosterone is also being used in the treatment of chronic venous disease. Of course, it is off-label use. It is recommended by many guidelines and consensus, that is European Society of Vascular Surgery, Society of Vascular Surgery, and the American Venous Forum, and it is strongly recommended by Indian consensus on the treatment of chronic venous disease. You will find that it is useful in all stages of chronic venous disease, that is from stage 1 to stage 6. And author also says that it can be used in suspected cases of CVD. You have not done a Doppler study and still you are not confirmed a chronic venous disease in the patient, but still you can continue. You can start using aldosterone or MPFF in these patients. Now, what are the effects in the chronic venous disease? It effectively improves the symptom. It has been observed that it is highly effective in improving the leg pain, edema, and quality of life in patients with chronic venous disease. Now, this is very interesting. Many patients, they say that they have a standing job, and when they come home in the night and they try to sleep, they get a lot of pain in their leg. They also get a swelling in their leg. So this is one of the important signs that wherein you suspect chronic venous disease in this patient. High level of suspicion is required for diagnosis of chronic venous disease. Otherwise, you will miss the diagnosis of CVD, and patient will keep on taking non-steroidal anti-inflammatory drugs for the long period of time, which will have its own effect on the patient, but it is not going to relieve the symptoms of the patient effectively. It also accelerates the venous healing, wherein you will find that there is a 32% better chance of venous ulcer healing as compared to placebo, and you will also find that the ulcer healing is a faster. As compared to placebo, the ulcer healing is 5 weeks faster than the in the patient who has been given MPFF. And long-term study, yes, the safety study are there up to one year, wherein you will find that efficacy and safety is confirmed even after 1 year of administration. So it is very well tolerated, and some of the patients may complain that they may have abdominal pain, and they may have some nauseating sensation. Now you will say there are some other formulations like Thank-OD or Euphorbia prostata, which is available in the market. So how you compare this aldosterone or MTFF with the Thank-OD or Euphorbia prostata? It has been observed that this Euphorbia prostata, it causes the dry mouth. That is one adverse event. And second is when it is used along with anticoagulants like aspirin or clopidogrel, it may increase the chances of bleeding. So it has interaction with these medications. So you need to be careful if patient is on these medications like aspirin or antiplatelet or anticoagulants. Then another medication which has been commonly prescribed is calcium dobisalate. Now calcium dobisalate, the evidences are a moderate level of evidence with calcium dobisalate. And second most important point is it also causes agranulocytosis in 4% of the patient, which is a huge number. So we have to be careful if you are using calcium dobisalate, say for a long period of time, or to some extent Thank-OD if you are using it in the patient. So with this, now we will go to the question answer session for today's talk. Now, sir, from my side, I would like to ask a couple of questions on aldosterone and the management of the treatment. Sir, there is a very common question from general practitioners regarding laxatives and fibers, that in patients of hemorrhoid, we need to use them for a long period of time because we need to regularize their bowel, we have to train them for the bowel, increase their fiber content. So we are always worried about the habit formation with the laxatives and the fibers. Your comment on this, sir, are they habit forming or not?
Yeah, many of them are habit forming, especially liquid form of agents like, you know, Crimafin Plus and all those products. They are habit forming, but bulk forming agents usually, which have more of fiber content which it gives, they are not so much habit forming as these liquid agents.
And sir, which one you prefer? I mean, which fibers you prefer in your practice? Like
bulk forming agents, I always prefer for treating constipation than liquid forms.
Right, sir. Do you prefer Isabgula formulation or some other formulation?
Yeah, Isabgula, Lactitol, all these formulations are better, you know, than liquid paraffin, because liquid paraffin is a very habit forming product to the patients.
Okay, sir. Okay. Sir, you said that during the diagnosis, we need to do a colonoscopy. So you recommend colonoscopy to all your patients, or you prefer them? So which patient I should prefer to the colonoscopy?
Basically, that is why I always told that history is very important of the patients. So history taking has to be perfect, where you will know whether basically the bleeding is the cause because of hemorrhoids or some other problem internally. Even on per rectal examination, as I told you, many a times if there is a CA rectum or something like that, you can feel it at the tip of the finger. And usually CA rectums is very common in young patients. I have had a lot of patients who come with hemorrhoids to you and saying that it is bleeding and they are asymptomatic, but when you do PR, you can feel a growth at the tip of the finger. And then so there you are in a problem. If you go ahead and operate only hemorrhoids, the patient will come out at a later date with a big growth. Ulcerative colitis patients, quite a lot of them present with profuse bleeding, and they have sometimes fissure or hemorrhoids associated with it. So you have to be really careful. Two things have to be done is per rectal proper examination and proctoscopy to confirm the hemorrhoids, fissure, or whatever is the problem. And if the bleeding is coming from higher up on proctoscopy, then colonoscopy is a must.
Okay, that's great. Thank you very much, sir.
Colonoscopy is an expensive procedure, especially here, because
Yeah.
patients have to spend a lot. So, you have to really select the patients for colonoscopy.
Right, sir. Sir, suppose I am a general practitioner. I am sitting in my office, and on very first visit, if I say to the patient that you have to do colonoscopy, probably patient may not get agree. So,
Yes,
yes. So then, sir, what advice you will give it to us? I mean, how we should tackle these patients?
Yeah. When the patient comes first time, and if you examine the patient and immediately if you tell, nobody would agree. So first is, rifaximin, which is a local antibiotic. You can give that. Probiotics, you can give it to the patient. You can start the patient on MPFF, so that the bleeding is controlled initially. And in the next, and even bulk forming agents, lifestyle modifications you can advise. And when the patient comes next time, you tell him that you come for examination after passing stools, especially. So when he comes next time and when you examine and you feel that this patient really requires colonoscopy, then you have to advise colonoscopy.
That's nice, sir. Thank you for those wise words. Now, sir, second important question, which is very common for us, is pregnancy and hemorrhoids. If a lady who is having a pregnancy come to my office and we detect hemorrhoids in her, how we should manage that patient?
See, a lot of patients who in pregnancy have hemorrhoids, have fissure, because constipation is very common, plus the baby's head is there, which causes venous pressure. So, as I told you, it is the man who pays penalty for the erect posture. So hemorrhoids is very common post-pregnancy, in pregnancy. So when a pregnant patient comes, in the initial 3 months, it is better not to give much medication and advise to take more fiber and take sitz bath to the patients, so that the symptoms get reduced and psychologically patient feels better. But MPFF and other treatment can be started, as you told, after 28 weeks, which is most common. The patient usually come during that period, because once the child grows to 28 weeks, then it causes pressure symptoms, and then the patients come with these hemorrhoid problems. So that is the time when safely we can start MPFF, and we can give lifestyle modification, fiber diet, if required, bulk forming agents to the patients.
Okay, thank you, sir. Now, sir, regarding use of aldosterone in liver compromised patient, this is a very common question being asked. Suppose the patient is having compromised liver function. Now, we try to search in a literature. Literature says that in animal studies, it has been observed that it is having safety effect or antioxidant effect on the liver compromised patient. I would like to know, sir, so however we advise a caution to the patient, I would like to know, in your clinical practice, when the patient with compromised liver comes, do you use aldosterone or MPFF in these patients?
Definitely.
And how you manage these patients?
Yeah, definitely, because most of the cirrhosis of liver patients have hemorrhoids, because the arteriovenous fistula formation is there, and that is common, and that's why they have huge hemorrhoids. And it has been found, in my clinical practice, I have been using what doses I have told, as 1000 milligram or 500 milligram, first 4 days, and then 3 days, and then for 2 months. I have used, and I have not found any problem with cirrhosis of liver patients. Even though sometimes LFT is deranged, still I have not found any problems.
Okay.
Basically, they say flavonoids is an antioxidant and an anti-inflammatory agent. So
right.
That is why, in fact, they say that it helps in these patients.
Right. Yeah, absolutely right. And what about renal failure patients? We don't advise because we have no studies. So any experience in renal failure patients?
Yeah, actually, creatinine up to 2, I have used it, but beyond that, I have not used it. I always tell them that please consult a nephrologist and then come back to me. This is what is the protocol. but I have not got such creatinine compromised patients with piles.
Okay, perfect, sir. Now, sir, comes a very important question about patients who are having chronic venous, heart disease, ischemic heart disease. And these patients are on medicine like clopidogrel and aspirin. So I have two questions now. I am a GP. I am sitting in my office practice. Such patient comes to me. He's saying I'm having a bleeding. Now I want to start him on MPFF. I can start him on MPFF. What should I do about his clopidogrel and aspirin? Shall I stop it for a few days or I must continue that?
I think it is advisable to stop it for a few days because it is counteracting both. You know, one side you are giving him a bleeding agent, but really speaking, I don't think MPFF interferes in any manner. But still, it is advisable to stop for about a week because acute bleeding has to stop. And since the blood thinners are on, the acute bleeding, even if it clots, then it will not be able to clot. Again, when there is, he passes motions, and if there is any injury, he will start again bleeding profusely. So that is why I think about a week, you can stop safely and put him on Eldospin, and then it can be restarted once the acute bleeding is stopped.
Perfect, sir. Perfect. Thank you very much, sir. Now, sir, you have spoken about it. Now, sir, this one more question which is very important. Now, in case patient is not prepared for the surgery, patient is saying, I'm not ready for the surgery. Doctor Sahab, I don't want to go for the surgery. Or he's not a suitable candidate for the surgery. How long we can continue MPFF in these patients?
It's a big joke, as I told you, that patients have been coming for 5 years to me and they keep, abbe agli baar main operation kara lunga. They are never willing for surgery because surgery for any person, it's the last option when all other options fail. So what I feel is that, as we have told, that, you know, first dose, when patient comes with acute bleeding, you can give him for 7 days acute dose, that is 4 days, and 3 for another 4 days, 3 days, and then you can continue for 2 months. Usually the bleeding stops, patient's symptoms have improved quite a lot, and you know, if he does lifestyle modifications, he is all right. But again, lifestyle modification is a big question. So again, he does the same old routine things, and then after about 6 months, he comes back to you. Again, I repeat the doses because he's not willing for surgery. So I feel safely up to 2 months you can use it. And 5 years, some patients have been coming to me, and every 3 months, 6 months, they keep coming and we have to give medication to them.
Okay, sir. Perfect. Achha, sir, one more question. Along with MPFF, suppose a patient comes to me in OPD, he is having a bleeding. So along with MPFF, do you advise any other treatment to these patients?
Yeah. Bulk forming agents, I told that. Plus locally, I give them xylocaine jelly to apply, or, you know, astringent ointments to apply. Then I advise sitz bath to them with betadine, so that, you know, symptomatically he feels much better off with sitz bath after passing motions, because whatever inflammation is there in and around the anus, that gets reduced. Of course, people say there is no evidence that it helps in recovering from hemorrhoids. That is true, but at least symptomatically, patient is much better with sitz bath along with these medications.
Okay, sir. Perfect. Now, sir, Dr. Jatin Choksi from Mumbai, he is asking that what is your experience and opinion about DGHAL?
No, I have not much experience about it.
Okay, perfectly fine, sir. Now, sir, we have answered almost all the questions of our audience or our viewers, or which are the commonly asked questions.
Because Doppler guided hemorrhoidal artery ligation, I don't know how many people have been doing it, and I have never performed that.
Perfect. Perfect. That's a very honest answer, sir. Thank you very much for that. So, sir, we have answered almost all the questions of audience. So, once again, I thank you for your valuable time and very informative and illustrative presentation. Now I request our colleague, Mr. Sujit Perde, to give vote of thanks. Over to you, Sujit.
Yeah. Yeah, good evening.
Good evening.
Let me extend my sincere thanks to very eminent and very senior speaker, Dr. Dinesh Hegde, for conducting this interesting and quite engaging educational webinar. Thank you, sir. We would also like to thank all frontline COVID fighters and healthcare fraternity for caring and saving many lives during this ongoing pandemic. My sincere thanks to all participant doctors who are registered with us today and connected to this live session to become a part of this educational initiative supported by Sun Pharma. I would also like to thank all my field colleagues, Dr. Abbas, head of his team, Ranveer sir, Nishanji, Snehal, and head of our Maxim division, Amit sir, for making this webinar live, come live for all of us, and really enjoyed. Thank you once again, all of you. Stay safe and stay healthy. Thank you so much.
Thank you all. Thank you, Sun Pharma.
Thank you. Thank you, Dinesh sir.
Thank you, sir. Thank you for an interesting session.